Good morning, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with the SWORBHP Hospital. Thank you for joining us for another webinar presentation. This one we'll be talking about the Naloxone Program. So I'm sure you've heard of Naloxone kits out in the public, so we thought we'd address some of the questions that have come to us since the release of that program. So presenting today, we have our Regional Medical Director, Mike Lewell, and our Local Medical Director in the London area, Mike Peddle. If you have any questions throughout the presentation, feel free to type them to me in the question box at the bottom of the control panel. I can either answer them for you, hand them off to the presenters, or we'll collate those questions and then give them back at the end of the presentation. If you have any questions at the end of the presentation and you happen to have a microphone, you can click on the little hand icon, and that shows me that you've raised your hand and want to actually say something live, so I can unmute you at the end of the presentation. And then we can answer those questions live as well. So once again, if you have any questions throughout the presentation, and we encourage you to ask those questions, go ahead and type them in the question box, and I will give them to the presenters if I can't answer them myself. And so without further ado, I will hand this presentation over to Mike and Mike, and we'll get underway.
Thanks a lot, Steph. And if we can use the same icon in case you can't hear Mike or myself very clearly through this webinar, that'd be great. Let us know, and we can try and adjust our volumes accordingly. So thanks again for logging on today and listening to our talk on the Naloxone program. This has come to our attention that obviously there's a clear disconnect, and maybe this is the best place to start. There's a disconnect between the public health initiative of releasing naloxone to citizens as well as versus what EMS is doing and what paramedics have been doing in Ontario with regard to the use of naloxone. So we wanted to take this opportunity to sort of clear the air as to what the base hospital's role has been with naloxone, as well as talk a little bit about the influence of what our medical directives are going to have upon this, and also get some advice and understanding as to what the initiative from public health actually is going to be like. Therefore, when you arrive on scene as a paramedic to render care, you can understand exactly what the kits that people have are, what they've been told, what they've been taught, what the background is, and then we can understand how to best blend these patients into our caseload as paramedic services. So what we've done is we reached out to our Middlesex London Health Unit, and I realize this is Southwestern Ontario, it's a regional program, but this is what we were provided from the local area here. So very similar initiatives, as you'll see, are happening throughout the province, but this is exactly the actual presentation that was used for the London rollout of this initiative. So very similar things will be happening to the Grey Bruce area as well as to the Windsor, Essex, Chatham-Kent areas as well. So the kits are very similar, just the slides are unique to London, so nothing more than that. So what's been happening is that there we go. So first of all, let's start off with what is naloxone. So naloxone is a medication, also you've also heard it referred to as Narcan, and it's used to reverse the effects of an overdose with opiates. And the main cause of death with opiates is the respiratory depression. We're going to get into a little bit, Mike, about the toxidrome that you tend to see, or the clinical presentation you see with opiates. But suffice it to say that it's more of an apnea. They actually just stop breathing, their carbon dioxide climbs, and although they can maintain their saturations on oxygen for a prolonged period of time, the fact that they're just not actually breathing leads to a bradyarrhythmia and eventually respiratory depression and death. And the key was to intervene with naloxone is to reverse that, but it's not without its own side effects. The question in our mind is why would this be released and why do we need a naloxone program? And it's becoming clear that given the opiate emergencies we have now, the abuse of opiates, Mike, you and I worked in the emergency department in London all weekend together, and I'm not sure how many cases we saw between the two of us of patients that were struggling with opiate addiction and also opiate misuse. But it's really quite striking how when I started 15 years ago, things were mostly alcohol related, but now we see opiate abuse as one of the most common forms of abuse.
Yeah, exactly. I mean, we see it pretty much, you can guarantee every shift you're going to see something related to opiates within, at least in our emergency departments. And surprisingly, some of the data that's come out about London and the Middlesex area is that it's a fairly popular medication of abuse within our systems.
Maybe it's a good point to talk about, too, the type of opiates that we see in Southwestern Ontario, not just London, would be things like prescription opiates, like you see with with your oxycodones, your hydromorphones, and your long-acting substances like this, which is very key to the Naloxone program, versus when you work in inner city Vancouver, inner city Toronto, or some of the places in the U.S., heroin is the #1 opiate. And one of the key take-home messages of today is that the length of effectiveness of naloxone is highly effective if it's a heroin because of the short half-life of heroin, versus some of our opiates. For instance, if someone eats their fentanyl patch, it can be, which we do see fairly regularly, that could be an opiate that can last in your system for 2 or 3 days. Whereas, so the type of opiates we see in Southwestern Ontario are very different than what we see in some of the rollouts of Narcan in heroin endemic areas. There's not a lot of heroin in Southwestern Ontario.
No, exactly, and that's one of the things that we'll try to highlight today is the understanding of how Narcan works and its duration of action, and how, while it works very well in the heroin populations, it does change how we have to treat them in the prolonged sort of prescription use populations.
Right, which by far and away is very clearly one of our largest drugs of abuse is the prescription drugs. So this Naloxone program, it's interesting how these things roll out provincially. It comes through public health, and in London specifically, it was done between the Middlesex London Health Unit, the Regional HIV/AIDS Connection, and also the London Area Network of Substance Users. So I'm sure in every other community, like in Windsor, and Grey Bruce, and Huron, and Perth, it tends to be similar sort of health units that roll these out as well. They basically identify clients that are at risk for opioid overdose, and they're provided with a brief education package on overdose management, and they provided the actual kits that contain the antidote naloxone. This is not, we're not unique in this, and this has been going back in the 90s. You can see that the Europeans first cornered this. Yet again, this is probably based on heroin addiction as opposed to oxycodone. We didn't see nearly the same amount of Percocet and oxycodone and also hydromorph abuse in the 90s that we did, whereas heroin was really a big designer drug then. Then the U.S. picked up on this in the late 90s. The Canadians then started rolling this out in Edmonton and also into Toronto and British Columbia in 2011. And then Ottawa's come on board as well. So now we're sort of seeing this expand through all the different public health networks. And unfortunately, I don't think that the interface, well, let me phrase it this way, perhaps, the interface could have been better with regard to public health interacting with our paramedic services to be able to explain this initiative, where it's coming from, and also maybe to mesh a bit better with the scope of practice for paramedics to understand when they should be released and who should be giving the drug and what the side effects are. Because clearly the training of our paramedics is far superior than our citizens, far superior in terms of recognizing the signs and symptoms of opioid overdose and also how to manage them. And as you'll see, the training that goes out to the citizens are fairly rudimentary. So I think we're going to get into some problems where we have either patients giving the drug when they shouldn't have given the drug, giving the drug and in situations where the drug that they actually overdosed on wasn't actually an opiate, or we may see them actually give the drug, wake the people up, EMS then arrives, and all of a sudden we have a safety issue with our paramedics where the patient's really combative and acute withdrawal, and then what do we do? How do we manage that?
Exactly. It's going to be a bit of a challenge to sort of, and we'll talk a bit about how to address some of those issues when you're on shift.
Great.
So we'll talk a bit about opioids for people that are familiar with them and have seen them in clinical practice. You know, there's a bunch of different types. As Mike has already alluded to, heroin is the sort of common substance of abuse depending on where you are, more inner city, Toronto, Vancouver, as opposed to what we're going to see in sort of the southwest region. Really what you're looking at there is more of the medication-based morphine, codeines, the semi-synthetics, which are kind of made, but not quite as much, so the oxycodones, the hydromorphones, dilaudid, and then methadone, which is used in the treatment of opioid addiction.
These also work by binding our natural opiate receptors, and what I learned during medical school, and we both learned during medical school, was the fact that there's different types of opiate receptors. That's therefore, you can, some give you more euphoria, some give you more just direct pain relief, and others give you more of a sedative, sort of dysthymic reaction where you're more just, your pain is controlled, your physiology thinks you're under control, but there's no real high from it, and that's why medications like methadone are quite effective in controlling your body's craving for narcotics and opiates, but not necessarily providing a euphoric stimulus. Therefore, the desire for certain types of opiates vary in the field.
Exactly. Exactly.
I think that how fentanyl was first discovered, and I may be wrong on this, but I think I remember reading that fentanyl when it first hit the streets is that there was a rash of a whole bunch of increased deaths in some of the areas of Southern California. They found that there was actually a new synthetic drug on the street, and they actually found that it was a version of fentanyl. That then became perfected, and that's how then the synthetic form of fentanyl came on board, and that's why trying to figure out dosing regimes of that's why it's in micrograms versus actually milligrams.
Wow, I haven't heard that story before, so that makes sense.
Yeah. So a lot of these drugs aren't necessarily synthesized by reputable pharmaceutical companies.
To start, exactly.
So for those of us, we've all managed opioid overdoses, obviously as paramedics and as frontline healthcare providers, as emergency physicians. Opioid overdose is a very common presentation, but let's just review what it generally looks like. It occurs when a person uses more than a drug or a combination of drugs the body can handle, and that's the overdose. They then develop, as we alluded to before, a depression of the respiratory system that can lead to death, and that's the key. I must tell you, like the patients that I see, I'm always impressed. Like they come in with relatively stable vitals. Their blood pressure is 90 to 100, 50 to 60 diastolic. Their heart rate's about 50, 60 in sinus rhythm. They actually will be satting very well. Their sats will be like 89, 90. But even up to 100% if they're using supplemental oxygen. But the key is that they're just not breathing. If you actually take a careful look at their respiratory rate, you'll notice that they'll be breathing at about 6, 5, even less, unfortunately. And what we can't measure, we don't measure routinely, is their carbon dioxide. And we may notice when you actually hook them up to a CO2 detector that we may have numbers in the 60s, 70s, and 80s. And that's the real problem, because that acute respiratory acidosis leads to a profound imbalance in their pH system, and then that's what causes them to unfortunately pass away. So it's the management of that respiratory depression which is the key to managing a successful opioid overdose.
Yeah, and exactly like Mike said, it's kind of the canary in the coal mine is the respiratory rate to watch and sort of see how much they're breathing.
Yeah, really, an opioid overdose is a successfully very comfortable looking person.
Yes, it's an easy trait.
They look very comfortable. They're like, hey, this person looks very comfortable. That's because they have a massive therapeutic dose of a narcotic, so they seem in their happy place. Unfortunately, when you wake them up, they become very not in their happy place. And I think that one of the other issues to understand is that there's a whole bunch of patients on the street, home remedies, if I could say, for opioid overdose, which are burned in the urban legend. For instance, one of my most famous opioid overdoses I ever looked after was a guy that who had been took a whole bunch of opiates, and then his buddies thought that the best way to wake him up was to put him in a bath tub full of ice water. Sort of your own sort of ice water challenge, if you will. So, so he was in the bathtub. They left him there for the evening. So he was in there for about 6 hours. So when he came in, he was not only still unconscious, but he was hypothermic at about the temperature of 28 degrees. So it was impressive how difficult his resuscitation was. And believe it or not, these are healthy, otherwise people generally, younger people.
Yeah.
Therefore, you can restore their physiology. They have tremendous reserve, and they get up and they get going again. So within 24 hours, this guy, I remember he drop-kicked the ICU nurse and headed out his way, and we'd actually record temperature warning him through his abdomen, through a central line through his abdomen, and actually he basically ripped that out, which I thought was going to hurt in the morning. He walked out the door. I'm like, yeah, that was impressive. Yeah, I'm somewhere out there. There's a guy with a hole in his abdomen leaking fluid. But he's back somewhere. Regardless, so be aware that some of these home remedies of opiates you may find people in the bathtub that are quite profoundly hypothermic. Mm-hmm. So unfortunately, there's not a lot of, when you get heroin, you get opiates in the street, there's no real formula to describe how much of a certain drug will lead to actually an overdose in certain individuals, which is a real big problem because a lot of the drugs that they're being sold on the street, they may not be pure fentanyl or heroin, or they may not be pure morphine. They then crush these tablets up, which actually a lot of them have binder in them, which shouldn't be injected. There's no real way of knowing how much drug each individual is going to get. Besides, there's no real way of knowing how much some individual will respond to that dose. For instance, on the weekend, I gave a patient 5 milligrams of morphine and had to be switched, and they became bradycardic and actually fairly vagal with that because they've never had a Tylenol in their life, and all of a sudden they had 5 milligrams of morphine. Whereas other people who are used to addiction can actually potentially take 20 milligrams at a time and not phase them at all. So depending on the drug dosing, the concentration you're getting, and also the body mass of the person, their tolerance, we may see all kinds of overdoses depending on just those different individual case characteristics.
Exactly, and especially the other common issue is periods of and use their previous dose, which they've developed a period of tolerance prior to that, and so it's not uncommon in those scenarios that they'll take what they've previously been taking and have a pretty significant overdose because of that.
It's a great point. In fact, I was talking with one of our pain specialists recently who told me that even if you miss 2 methadone doses, they then actually, when you go back on methadone, they start you back even at half or actually at the basic level before building you back up again. So quickly you can become non-tolerant of methadone that they actually have to build you back up. So it can actually be very dangerous to actually combine different types of opiates. So even if someone's on methadone, decides to go off methadone, they'll start taking hydromorph, they can actually have a paradoxical reaction even if it's a small dose. So there's a lot of science to balancing the different types of narcotics that are out there. And unfortunately, for a lot of our patient population, I don't think they take this into consideration when they're using this drug. They could actually have a paradoxically terrible reaction when prior they could actually have taken that drug without any complication. So what's the difference between an agonist and an antagonist?
So the antagonist basically works in the opposite way. It moves things away from that receptor and basically antagonizes the effect of the drug that you would have otherwise been taking. So
kind of like a mother-in-law of the drug. The antagonist.
The antagonist. Yeah. No protagonist.
Oh,
just the antagonist.
Nice.
But basically it displaces the opiate, whatever opiate they are currently taking in this scenario. And therefore reverses the primary effects of the drug, and the most worrisome one for us obviously being the respiratory depression that they're having. We can give it intramuscularly, and this bottom comment here, the stays in the body active for 30 to 90 minutes is really the key thing when it comes to naloxone or Narcan, is that it only lasts for 30 to 90 minutes, and a lot of these medications last for much longer than that. Hours potentially, and so it's really important to remember that. The other thing is it starts working quickly, and it just because it displaces and reverses the respiratory depression, it also reverses all the other effects. And so quite quickly, especially if they get this dose, it reverses all of the effects of the opioid and puts them into acute withdrawal.
Yeah, I think that this is, if anything, the take-home message of today is that the drugs of abuse that we see in communities we serve are long-acting opiates in general, not the short-acting opiates. And yet, unfortunately, our antidote, naloxone, is a short-acting antagonist. Therefore, by far and large, when you give naloxone, it's going to wear off, and then unfortunately, the drug that they've taken is going to wear back on again, and they may have the same type of overdose. So when we're managing these patients in the emergency department, our challenge is that I can wake you up, we can wake you up, no problem. Then all of a sudden we have to manage you. So you are all of a sudden in acute withdrawal, you are combative, you're violent, you're harming your nurses, you're restraining you, and then potentially sometimes they actually get up and they leave, and then we find them unconscious about a kilometer away from the hospital, which is a real dangerous thing, obviously, for both the patient and also for the hospital staff. And expanding that to the pre-hospital care environment, we've had real adverse reactions with our ACP colleagues that have actually administered naloxone. We've had cases where they've administered it, the patient's woken up, become intensely combative, refused transport. So now you have a situation where how do you insist upon transport for these patients, whereupon they don't want to go, but you know that half an hour from now they're going to be back unconscious again, and you're the last person on scene. I've actually had a couple of cases where they became in the back of an ambulance and actually jumped out of the ambulance, and actually then we have a huge issue downtown. Imagine that you're sitting in your Honda, and all of a sudden there's an ambulance in front of you, and this guy runs over and gets IV, and the paramedic goes chasing him free. You're like, well, that's an awkward day. Especially if you didn't know anything about the EMS systems, too. You're like, well, that just seemed odd.
Exactly. How are you going to document
that? But imagine you're the person in the car behind him going, well, that didn't seem right. Anyway, onwards. But that's the key, is that we have, unfortunately, a therapy that is not exactly tailor-made for the actual underlying problem. And so, therefore, as paramedics, you're going to walk into a situation where someone may have given the antidote. You may walk into someone who's now awake, incredibly combative, and there's a safety issue for you as the individual, and also they don't want to go to the hospital anymore. And there's a huge safety issue.
Absolutely. These people can get very agitated and very upset.
And then if you leave, then all of a sudden, if they refuse transport, then you have a situation where the person is going to be back unconscious again. So this is where refreshing your 2 BLS patient care standards are so important. Number 1, the suspected overdose standard, which talks about maintaining contact with CAC, involving your supervisor, even involving the hospital physician or the police in a stepwise progression as listed in the BLS patient care standard. And also assuming a polydrug overdose, not just an isolated drug overdose, because unfortunately, you know, these clients oftentimes will take more than one drug in their pursuit. And that's another issue. If you unmask the naloxone, you may all of a sudden see so you unmask the opiate, which may be keeping them down, you may unmask the crystal meth that they've been having, which now all of a sudden is super agitated as well, or the cocaine that they have on board. So now you may see actual propagation of an underlying toxicodrome that may otherwise have been kept more dormant by some of the opiate. And the second BLS patient care standard to be involved with would be the refusal of transport. So if someone, you arrive, they're agitated, and they refuse to go, how do you know that it's safe to let that person be there? So the suspected overdose standard as well as the refusal of transport standard are 2 ones to be very commonly aware of in this situation. If you wish to, naloxone is not going to work for non-opiate drugs, but quite honestly, I don't think a lot of the patients in the field who are going to be giving this necessarily know the difference between the opiate and non-opiate based on this training. A lot of naloxone itself does not cause euphoria or dependence. It's just a true antagonist that's going to wake them up. It'll have no effect if you're not taking opiates. So if they're taking a whole bunch of benzos, for instance, Valium or Gazlam or Lorazepam, whatever they're clonazepam, whatever pan of the day they're taking. I think this is true because this is very confusing, the nomenclature. We think that in the field we talk about narcotics, and amongst the medical community we talk about narcotics as opiates, but in the field amongst addicts they talk about narcotics as just illegal drugs. Therefore, controlled substances, illegal drugs would be benzos and opiates and other drugs, whereas this is a narcotic / opiate / true opiate antagonist, naloxone.
Exactly.
So if you then put them into prompt withdrawal, they get all kinds of agitation, anxiety, myalgia, sweating, nausea, vomiting. It's like having the worst flu all of a sudden in 10 seconds.
Exactly. Going from being very comfortable sleeping and all of a sudden waking up with terrible flu.
Yeah, it's amazing. Like, when you watch them, and there's a stepwise progression as you give them naloxone. What will happen is that you see them initially still yawn, so now they're actually taking their first big breaths. They'll start to move around a little bit. They'll start scratching their nose, and all of a sudden they'll take away their because there's a histamine release associated with narcotics. They'll get a little bit itchy. Then also they'll take their oxygen off, and all of a sudden they'll sit bolt upright, get all sweaty, and go, "What's going on?
How did I get here?
You're like,
what did you do?"
Well, I'm sorry if I cut off all your clothes. Okay, so how did this go? How did this actually roll out in our communities? Well, they actually we meet with the different healthcare units, and the public health nurses actually meet in London. They actually met the Middlesex London Health Unit. They met with the Needle Exchange staff at the Regional HIV and AIDS Council, and also some of the nurses and frontline outreach staff also met with the different clients.
Health program as well.
Wonderful, and that tends to be where a lot of our opioid abuse tends to be in our community. And I'm sure across Southwestern Ontario it's the same in your individual communities. You see there's 20 to 60 minutes of training. Now, I don't know, maybe that's based on their ability to have attention span. But it's also the amount of time that it takes to sort of at least show them that here's the kit, here's how you give it, and then out the door they go. Clearly, we are not talking about trained providers here, and this is why we're going to see misuse of the drug or inappropriate use of the drug, and potentially giving the drug when it's not indicated to go. Here's what they're basically taught, Mike.
Yeah, I mean, they're being taught to call 911 before giving the medication.
Good.
So trying to have help on the way, give the naloxone. And then the other thing that will potentially come into this is they're talking about chest compressions. So if they're still unresponsive, just start chest compressions. So you may come into the scene and see people doing chest compressions on someone that may or may not actually need it at that time.
But I'm sure our highly skilled paramedics have seen that before, where someone stands up and does chest compressions to someone and wakes them up. But then again, I mean, it's a good way to wake someone up.
It is.
But at the same time, I'm hoping that we don't have too much inappropriate CPR happening in the future. Shake and Show concerns me a little bit too about how violent we're going to be waking these people up. But we do know that a lot of these patients require a painful stimulus to actually open up their eyes and breathe.
Apparently, in the training manual, they are saying don't kick or punch.
Well, that's good. Helpful.
Yeah.
Good.
Take or punch them, don't burn their feet was another comment. So
Amazing.
yeah.
Amazing. Yeah. Well,
similar to the don't put them in ice water.
Seems reasonable.
Yeah.
And then, so for us, this is what the environment you're going to be walking into. And here's the kits, and they consist of two amps of naloxone and 2 actual amp openers, 2 amp snappers, 3 retractable syringes, some non-latex gloves, and a rescue breathing barrier. So, because remember, a lot of these patients will be hepatitis C positive or HIV positive, so there's significant infectious disease risk. And now we're going to also have new needles going IM into these patients as well, so there's going to be blood available, and those syringes are going to be most likely open and non-capped, sitting in the environment as well with a fairly agitated patient. So a huge safety issue for our paramedics. We have client identification cards and 5 steps to save a life instruction. Yes, there is 5.
5 steps.
5 it is. I wish I should write them down on my arm. Check 1.
All right, let's start.
Okay. So how does it actually roll out? Well, naloxone is provided by the Ontario government, and there's other different initiatives across the actual province, like the Ontario Harm Reduction Program, and it's going out through the distribution of needle programs. And basically, it's a partnership between the Naloxone Program with the government of Ontario and the various social agencies. And really, unfortunately, missing from this was really a clear enmeshment or a recruitment of the paramedic system to be able to say, look, okay, this is how it fits with us. So we're left a bit scrambling, and so that's why we're trying to roll this out today with everyone to get you aware of what you're seeing. Plus, we've been actually very active with our provincial partners trying to get changes to our medical directives released from the Ministry of Health to allow a bit better broad use of naloxone, and we'll touch on that just at the end.
Exactly. And like Mike said, I mean, unfortunately, we're coming into this very late. The discussions about this program started back in 2012. And continued through 2013 with the various provincial partners, and then into sort of late 2013 with the Middlesex Home and Health Unit, the intercommunity health programs, and the HIV and AIDS community programs. And then started the community stakeholders, so discussions with some of us started sort of towards 2013 and into the beginning of 2014 when we were told that the program was coming.
Right, and so our work then has been to try and understand exactly what's being released, being able to look at trying to figure out how this is going to best interact with our paramedics on scene, and then how can we adjust our medical directives for to account for this new release. And to be honest, working with the ministry, we know that to change medical directives for paramedic practice takes time. We don't have a flexible and nimble system, and unfortunately to meet releases like this that change, we need to have a much more flexible and nimble system to make changes. And specifically what we're talking about is trying to be able to broaden the scope of practice of primary care paramedics to allow for naloxone use. And at the provincial Ontario-based hospital group, there's wide support of this. And I must say, unfortunately not unanimous support, but the Southwestern Ontario regional-based hospital has definitely been supportive of it, increasing the scope of practice for primary care to reflect naloxone use for PCPs, which must come with an education package to get you up to speed as to what an opioid overdose looks like, how to administer this, and then also what the side effects of actually the drug administration is. Mm-hmm. But I think it's key, if we're allowing citizens in the community to administer naloxone, we need to have our PCPs to be able to do the exact same thing. So that's going to bridge that gap to the disconnect. I wish that happened in May. As we know, medical directives, we have about 4 or 5 medical directives that have already been endorsed by the Ontario-based hospital group, MAC, but it's important for people to understand the politics. Very briefly, the politics are that the Ontario-based hospital group makes recommendations to the Ministry of Health. We can strongly recommend things, we can vote on things, we can endorse things, but until they're released to them by the Ministry of Health, they're not actually put into practice. And at the end of the day, we provide advice and direction to the Ministry, but we aren't the Ministry, and it's up to the Ministry to release them. And so that's where we're at. So we'll continue to advocate for this broadening of the paramedic scope, further education for our paramedics. I don't like these disconnects. None of us like these disconnects that come up, and they're not confined to just things like this. There's other initiatives that are happening in communities, dialysis for one, for instance, that happens where there's a disconnect between paramedics and public health initiatives. But we're trying to work together to try and bridge this, and hopefully we'll see some changes coming up. This is the program that was released. Now, we've actually had some questions provided to us by paramedics that we want to sort of address as part of this webinar related to this. And also, we wanted to open the floor to have some questions from people online to see if anyone was had some questions for us today. So, Steph, if there's any questions for us yet, we'll maybe answer some online. Otherwise, we'll move ahead to our questions you've been submitted ahead of time.
Yeah, go ahead and start with that, Mike. I do have a few questions that have come through, and I'm going to organize them for you. So go ahead and start with the list you have.
Great.
So, Mike, I'm going to read through some of these questions for you, and we can address them as we go through. So we'll start with this question here. So the first question is, we know this will be a PCP directive soon. The question is, from both the ACPs and PCPs, is we still have to patch for this medication, even though the public can give it. We know the risks. We should be treated as professionals and not have to patch for this drug. So would you like to address that one?
Sure, yeah, great. Yeah, that's a great question. So I think that speaks broader to why do we have patch points into our medical directives versus why do we not just allow paramedics to practice as professionals? Well, personally, I don't think there's a link. This is my personal take. I don't think there's a link between people being a professional and requiring a patch. I think that more than anything, by patching, you do two things. You consult with a colleague to be able to say, look, this is the situation. I'm looking for some advice and some direction. Because realizing that offline medical control protocols or medical directives that are written down can't account for all the unique aspects of every call. So maybe you're 4 minutes away from the hospital. Maybe you're 35 minutes away from the hospital. Maybe the person's apneic and not breathing and being bagged versus actually maintaining a sat and breathing but still got a GCS of 8 or 9. So how do we account for each one of those subtle nuances with each individual patient presentation? That's what the patch point's built in there to do, is to say, look, what do you think? Like, here I am, I'm 6 minutes away from the hospital, the guy's breathing, I'm not bagging him, but his GCS is 9. Should I give him the Narcan or should I transport him? In that situation, you know what? I'd probably hold off in that situation, knowing that they're still maintaining the SAT, they're still breathing, and they're going to sleep this off, and then we're not going to precipitate an acute withdrawal, we're not going to precipitate a potential safety issue with an agitated patient, but to transport that patient. And you know what, in the emergency department, I would actually observe that patient. Let them slowly wake up so don't precipitate that same sort of safety crisis in our emergency department. If you wrote a protocol that said, opioid overdose, unconscious or decreased level of consciousness, give Narcan, that person would then get Narcan, and all of a sudden they wake up, we'd have all those complications. First, the 35-minute transport with someone that's being gagged, for sure I'd say give that person Naloxone. So the patch point's built in there for that judgment, and that in recognizing that many paramedics can make that judgment themselves. I totally agree with you, but then again, if we look at the Southwestern-based hospital as a whole, the number of Naloxone doses given by each ACP per year is not that many. This may happen 1 or 2 times a year to some ACPs. It may happen to more often. But this happens very routinely in the emergency department, the emerge doc. So maybe that it's more of a shared liability piece and more of an experience sort of sharing that allows the patch point. And that builds the second point for the patch point is the liability factor. You know what? Maybe it's unfair if you do this decision 1 or 2 times a year to be able to say, this is my decision, I'm going to make this decision, I'm going to give this drug. Or it allows you to share the liability with the patch doctor. Say, look, the guy was unconscious but still satting well and breathing well. I consulted with the base hospital physician and they told me this. Well, you know what? That puts you in a much more strong legal position or a liability position where you're having an endorsement of the base hospital physician to say transport. So I'm sorry that anyone feels that a patch point is feel that we're not treating as professionals. I think it's more of a let's consult with everyone we have around us, use the resources we have to make a unique individual patient decision in real time, and that's why I think the patch point is built in there. So realizing that this is not an innocuous drug, and I think that's the real thing, both from a safety point of view and also precipitating an acute withdrawal. Like there's another question we have, which if drug has been taught us to use Naloxone, why is it not in a PCP bag? And I think we've sort of addressed that, but we think it should be in a PCP bag. So exactly. We're working ahead with the province to sort of put that in. Exactly. Now this is some other questions.
We've got about 5 questions that have come in online already. So first question is, what is the dose of Narcan in the public? And the dose is 0.4.
Right, and there's two amps of 0.4.
Exactly.
And then in most patients, that'll wake them up, to be honest, at least at some level, at least to the point that they'll restore respirations, I'm hoping. But we see sometimes doses up to 2 milligrams or even a lot larger than that, requiring to fully restore someone's level of consciousness. And in the case of the fentanyl overdose, that they actually eat their fentanyl patch, we've had to actually admit people to the ICU and maintain them for 2 days on a Naloxone infusion. So exactly. That's our concern. If someone all of a sudden eats the fentanyl patch and then we give them naloxone. They may wake up initially and then refuse transport, but we know that person needs long-term admission and fentanyl patches. I remember my first fentanyl year, I couldn't believe how sedated they were. Like, I thought for sure we'd give them like 0.4, 0.8, then 2, and then they'd be okay. And then, but literally every hour I was giving this person 2 milligrams of naloxone, at which point I think they required 2 days of hospitalization. I just couldn't believe it.
When you think about it, there was 3 days worth of fentanyl in that patch.
I just couldn't believe it. I had this picture of like this fentanyl patch stuck to the inside of his jacket.
Just absorbing a little faster than otherwise.
It's like that childhood myth you hear when you swallow bubble gum, it's in there forever. Same with fentanyl.
Forever. And so the next question we have is addressed a couple of times, actually. We've had a couple of this question come in, so we're going to address it all together. So the question is, if we arrive on scene and a bystander with a kit says they are uncomfortable giving Narcan and then ask the PCP to give it instead, how would a PCP best respond?
Great. So, and we've got a couple of questions related to in your handbook on page 8 under Home Medical Technology and Novel Medication section. It was written to address situations like this where there's a disconnect between what a community organization that has versus what we in pre-hospital healthcare can actually provide as paramedics. It actually states in that area that a paramedic may only assist a patient within the authorized paramedic skill set. So basically designed to say we have to have confidence that if we're going to release medications to trained, and I use the word in quotation, trained providers in the community, then it's up to them to actually provide that medication based on their level of training and oversight. If that medication does not fit within the scope of practice of the paramedics themselves, then you are not authorized to assist them in terms of giving that medication. So although you were trained to give it an IM injection, for instance, you're not trained to give an IM injection with Narcan at this point as a PCP. We want that to change, but therefore, in theory, you're not covered on the medication assist area based on our interpretation of that preamble that's in your handbook. So in this situation, I would not suggest that it's within the scope of practice of a PCP to say, I'm not authorized to give it, but here's how you do it, let me help you with that. Unfortunately, and this is the disconnect we're having, that this shouldn't happen. We want PCPs to be trained in this and be able to give this, and we're working with our province to go through this the proper way.
Okay. So the next question or comment is, in the field, giving half doses seems to be quite helpful in minimizing the withdrawal. Will that be part of the directive?
Great. Well, there's actually a lot of science looking at dosing of naloxone. In fact, based on some of the Vancouver work, there's actually some suggestion that giving a sub-Q 0.8 milligrams makes the patients wake up much more gently and therefore have a lot less acute withdrawal, thinking that the absorption through the sub-Q route actually works a bit better than IM and a little more gradual than IM, and also the slightly larger dose would be helpful for that. So I thought that sounds great. I remember reading about this and hearing about this from experts, so I'm going to use this in the word next time. Well, I gave 0.8, the person woke up like very not gradually, and so I was a bit disappointed by that. So you're absolutely right. Less is more in this. So yeah, if you give them small nudges of drug, it's certainly possible they may wake up more gently. And this is part of the patch point piece too, is when giving this drug, depending on the tolerance level, the amount we think they potentially could have ingested, you'll see different responses based on different dosing. And that's why I must say sometimes in the emerge I'll give 0.2, I'll give 0.4, and sometimes I'll actually give it, depending on the emergency nature, I get up to 2 milligrams push at a time. So I believe that to be true, that if giving a half dose may wind up being a more gradual awakening for sure.
And that comes back into the whole pattern in discussing the case as well, right? Sometimes the decision can be made to give the half dose or the whole dose.
Mm-hmm. Yeah, in emerge, sometimes we have patients that we keep them and we watch them to the point that we know they're safely breathing on their own, and eventually we have to get them home. But it's a safety issue. We don't want to have them home, and our worry is that we give them naloxone, we get them home, but then they stop breathing again. So we usually observe them to the point that we know that they are not going to stop breathing, they're awake enough that they can tolerate things. They may sometimes still be a little bit lethargic, and so maybe we can even give them a dose to go, and that way they're now fully awake, and then by the time they get home, the naloxone wears off. We know they're not going to come active again, but maybe they go hang out on the couch and just relax a little bit, but at least we have that bed back available to us. So that's the strategy I use in emerge.
I agree with that. I mean, and there's been a couple of comments along with questions, and we agree that, with how long it took, the comment as to how long it took for Toradol to change, and how long it could take for this to come in. Unfortunately, like Mike said, we can advocate to the ministry to say we should move these things forward, but it's a ministerial.
Yeah, I must say, and I think that if anyone can understand some of the frustrations of what we do for a living, I think that that's like, I think that people may think or believe that it's up to us at the base hospital to release things, and I really wish it was, because I think that we can actually see change happen a bit faster potentially if there wasn't necessarily those layers of approval that are required for release. Now, that being said, if the ministry is listening, I'm sure there's reason for all those different layers of approval, and it's not our system. We don't own the system, and we provide advice and direction and medical direction to the ministry, and then they can move through and make their change when they meet all their required regulatory functions. I wish it was faster. I'm sure that those that know me know that I've been frustrated with the pace of change eventually with some things. I think that those that are able to watch us work know that we've been strong advocates of change. We're doing our job as best as we can, pushing people. And I think that if you actually ask the ministry, they would tell you the same thing. They would say that the Southwest medical directors as a whole and as a staff as the Southwest have actually been agents of change, really pushing the envelope to the point they're tired of hearing us. But I think that's us doing our job. We can't make the move any faster when it comes to things, and I think this has definitely been on their radar as we need to move fast on this. I'm very pleased by some of the work by some of the other base hospitals, like our Durham colleagues and our Toronto colleagues and our Ottawa colleagues, really trying to move this through. So I'm hoping it's faster than our analgesic directive that took a year and a half, almost 2 years to get released, because it's an existing directive that we're now looking to move to PCPs. So I'm hoping that that allows a bit more of a rapid pace. I can't control that pace.
So we've got another question here, which may very well be the case as we've discussed, and we're not always sure when it's going to happen, but what if I don't know whether the overdose was an opiate and it was given? Will the patient react differently?
Great. I think that we're going to see a lot of this, like you said, Mike. We'll probably see a lot of people that overdosed on benzos or overdosed on a combination of benzos and opiates, and then when they got naloxone, they still could be just as unconscious, which actually, to be perfectly frank, is going to have very little side effect to the patient, and actually may make the patient management a bit easier, because you're going to still have the same decreased level of consciousness patient that you're going to follow your standard BLS interventions with and transport that patient. So hopefully, we probably will not see an adverse reaction. Pardon me. An adverse reaction from that, we're probably going to see minimal to no reaction from that, and it's going to be business as usual.
All right. So another question is, would police have the ability to put someone into custody if they refuse transport after receiving Narcan? That's a difficult question. I mean, unfortunately, police have various reasons or various sort of legal things that allow them to restrain someone and bring them to the hospital, including the Mental Health Act or something along that lines. Whether or not after receiving a medication the patient could refuse transport and then be taken into custody by police, I'm not sure that that would actually be able to happen.
Yeah, let me speak to that. I was at a coroner's inquest about actually something very similar to this, where a patient had overdosed and actually then refused transport. And although the basic life support patient care standard refusal of transport and also the suspected overdose standard talks about stepwise involvement of supervision, including police at one point during the refusal of transport, the police are very specific about what the police do is up to the police. And it's not up to us to be able to tell them what they should or shouldn't do. And I must tell you that they had a very impressive legal presence at that coroner's inquest. And even though, to the point that I wasn't actually able to read the basic life support patient care standard refusal of transport stepwise progression, the moment it used the word police in it, they actually interjected and then objected, and then I was stricken from actually saying the word police in the coroner's investigation. So I'd be reticent to comment as to what the police can or cannot do based on that. I would suggest that we should follow our basic life support patient care standard, which talks about involving the police, and then what they decide to do is really up to them, I must say. And we know, well, all of you know as paramedics that you've been involved in situations where I'm sure you can ask to medically clear patients on behalf of police. And so that's another issue altogether, where we have interactions with our police partners to when EMS and paramedics should be involved. I think that we have to focus on our own scope of practice and our own skill set and let the police focus on theirs, involve them, but then let them follow their own direction.
Exactly. And along the same lines is it likely that the use of restraint standard will be updated at the same time as?
Well, the use of restraint standard, I haven't thought about that one, to be honest. I think that, I don't know if it's going to be updated per se. I don't know if that's going to change or not. I think that we have to look at our own safety. We have to look at our own use of those. I know that, I mean, to be frank, all of these have a very big potential to go sideways, like we see with our excited delirium patients. We know that if you're the person that's going to be standing, no matter what you've done as an intervention, if you're standing at the foot of the bed when the person has a cardiac arrest as an excited delirium, you're going to be the person of note that's going to incur some liability in that. So if you're the person that's tying them down and they have their cardiac arrest, that's another issue as well. I think that we have to focus on our paramedic safety. We have to focus on our scene management. And if there's any concerns about safety, if restraints are indicated and used, well then we have to have good documentation and good supportive evidence of that and endorsement by our staff. And I think that maybe that's more of an operational question versus a base hospital medical question. Like we got another question here which talks about the seizure being a risk of naloxone or benzodiazepines and the PCP scope being considered. It's a great question. I think it's important to note that the use of controlled substances, and this is one of the barriers between ACP and PCP scope of practice, is that controlled substance legislation is actually a federal legislation. And in it speaks of what a controlled substance is. And a controlled substance speaks to benzodiazepines as well as narcotics and opiates. So opiates and benzos. This is controlled substances. In this federal legislation, it identifies that advanced care paramedics must be the ones to actually handle and administer controlled substances. This is one of the barriers to allow PCPs to then have any kind of analgesic that was not a non-steroidal anti-inflammatory or a Tylenol or a acetaminophen derivative, that type of thing. So the moment you get into opiates or you get into narcotics or benzodiazepines, it's advanced care scope as per the federal legislation. Changing legislation is, changing federal legislation requires an act of parliament. So that isn't something that changes quickly. Therefore, what you see, developing a PCP benzodiazepine directive would require federal controlled substance legislation change we don't see on the horizon anytime soon. Therefore, what we left here is with to manage seizures is an ACP scope of practice. Any other questions?
No, that was all the questions that have come in.
I do actually have one. Mike's, I do have one that's come through. The question is, would chemical sedation be appropriate if we wake a very agitated or violent patient in this case?
Well, that's a great question. So, and that's where we're going to be, I think, at our worst, is where we have confronted with a situation with a person that was initially apneic, required revival by the antidote, and now we're going to provide them another drug, a mixed drug, to try and make them more sedated again to be able to transport. As with anything, I'm not going to give you an exact answer for each one of these situations because it's going to require judgment. If the patient is absolutely uncontrollable and at a risk to themselves and violent, well then potentially they may qualify. And this is where the base hospital physician patch to be able to tailor the nuances of each individual case presentation to that is a reasonable alternative. A couple caveats to that would be mixing drugs, narcotics, like so opiates and benzos, does increase your likelihood of adverse reactions such as hypotension and apnea. So it would not be my preference to start there. The second thing is we cannot use the sedation directive for combative patients as a method of dragging people to the hospital if they have the capacity to be able to refuse. So I think that that's another issue that we have to be able to say, like, if the person's awake, surrounded by bystanders, says and meets all the requirements, the capacity for refusal, and then we're trying to drug them enough to be able to drive them to the hospital. That's not the purpose or the origin of the medical directive for sedation. So, like anything, there's no nevers and absolutes in medicine. There may be situations where it's absolutely indicated. I would suggest that patching at that point would be a very good idea to be able to try and control that for allow for the nuances of each case presentation.
So a couple other questions that came in prior to the start of the presentation today. So a brief reminder of what I might come across in terms of patient presentation during an opioid overdose.
Great. So we talk about in toxicology or overdoses different types of toxidromes or typical presentations. So what I like to think about is I like to think about for each type of toxidrome the classic drug that precipitates it. So for like the sympathomimetic, I think about cocaine. For my anticholinergic, I think about Benadryl or Gravol. And for the opiate toxidrome, I like to think of like your typical heroin patient. And typically those patients are pinpoint pupils. They are relatively lower blood pressure, but still relatively stable blood pressure, like 90 to 100 systolic. They're going to be relatively bradycardic because they're comfortable. So the heart rate's sinus rhythm at 50. They tend to sat well because a lot of the times you put them on oxygen, but the key is their apnea. They're just not breathing. So if that apnea persists, they won't be setting well at initial presentation. So it's they're relatively bradycardic, relatively hypotensive, pinpoint pupil, decreased level of consciousness, apnea person. It's like looks like they're fundamentally just sleeping. Yeah, they're happy and sleeping and just not breathing, sleeping. That's the problem.
There is the key.
It's
the breathing thing.
Yeah, well, it's the A. After A,
Exactly.
it's the B.
It's the B.
Exactly. They have a B problem.
Exactly. Not a problem. So how quickly does naloxone work? I think we've addressed it. It works relatively quickly in the first couple of minutes and lasts for about 30 to 90 minutes, which, once again, just to highlight some of those key take-home points from today, is one of the major issues, given that a lot of the drugs of abuse that we're likely to see in our region have longer durations of action than that 30 to 90 minutes.
It asks here, this question is, should we bring the bystander with us to administer a second dose, and if so long, how long after the first? Well, I think we addressed that in terms of the assistance with the MedAssist drug protocol in our preamble. I don't think you want to bring us the citizen to administer a second dose. By and large, too, I don't think that, given our transport times, that necessarily you're going, if you're not seeing any response from the 0.4, I don't think in the next few minutes you want to have them administer a second 0.4, especially on transport. I don't think bringing someone else to administer drugs in your ambulance is the best way of going about that.
Okay.
There's another question here. What if I don't know whether the overdose is an opiate that was given? I think that we answered that one already as part of this.
Yeah. And then there's another question here on Suboxone. So the question is Suboxone requires larger doses of naloxone, up to 2 milligrams. Is there ever an overdose of Suboxone, and if so, how would naloxone be used, if at all?
Sure. So sometimes we see Suboxone is kind of their maintenance of withdrawal. So it's a different sort of type of methadone, effectively.
Exactly.
And so I have not encountered a Suboxone overdose at this point. I am sure that if someone actually has taken an overdose of Suboxone, and if they have an opiate toxidrome, I'm sure they would have at least tried naloxone to help reverse that. I think the reality is that any long-acting opiate is going, if they have a long physiologic dependence upon opiates, you rarely reverse it. You may precipitate that acute withdrawal again. So it'll probably manage very similar to that, but I have not personally managed a Suboxone overdose. Have you know?
I've not seen one actually. So
I think that certain communities are big. It depends on the withdrawal management strategy. I think certain communities are big on Suboxone. One of my colleagues from Ottawa, certainly, actually one of both of our colleagues from Ottawa actually, is a big Suboxone advocate as well, and it's a special license you have to have for that. We don't see a lot of Suboxone in East and Southwest that I'm familiar with. Maybe perhaps in Windsor they have someone that has a Suboxone license, but so bottom line is, if there is a Suboxone overdose, we won't necessarily know at the time. If you do know, they may have received naloxone. Anyone that has any opiate overdose potentially could receive naloxone if you're an ACP currently, if you meet the indications, and they should respond like any long-acting opiate. They'll have acute withdrawal and the agitation that comes with that. Well, we're on the 12 o'clock, so that's been our hour, and I thank you for your participation and listening. I hope this has been helpful to at least understand what the protocol, what the initiatives that are happening in our community through public health have been like, the reason, the impetus for that, and what the kits we're going to look at. We hope you understand a little bit more potentially about what opioid overdoses look like in the community, and hopefully you understand a little bit about what the interaction between our providers, yourselves, and the citizens that are out there. As I say, if there's any take-home message, it's the discrepancy between the length of time that naloxone is going to work versus the long-acting opiates we see in our communities, lack of heroin in our community versus the prescription pharmaceuticals that people are using, and finally the fact that we certainly are advocates of having PCP naloxone out there, and we're doing everything we can within our power to try and implement that in a timely fashion to the province, and I can't say any more than that. Anything further, Steph?
No, that's great. Thanks, guys. I just want to say thank you to everyone who attended. I think it was a great webinar, lots of information on a topic that's really hot in the streets right now. So thank you for addressing the questions that have come through, guys. For everyone else who's watching, keep a close eye on your email, our website, and our social media. There will be some additional webinars coming up in the next couple months. So keep an eye on that. Otherwise, have a great day, everyone. Thanks again to Mike Lewell and Mike Peddle.